Hi, my name is Kristen Soto.
Hi, I'm Kristen Gerard. We're the Kristens. We work on measles.
And today we're going to talk about considerations for measles in a school setting. Today's presentation will cover background on the epidemiology of measles, information related to vaccination with MMR vaccine, and management of exposed individuals in a school setting during a measles investigation. To begin, we would like to provide you with background information on the epidemiology of measles. The information presented in these slides are current as of April 29, 2019. However, it should be noted that these numbers are updated by the CDC every Monday. A link to access current case counts and a list of active measles outbreaks has been provided in the slide deck. Measles is a serious viral illness characterized by cough, coryza, conjunctivitis, and high fever. This is typically followed by a generalized maculopapular rash that begins near the hairline and progresses downwards. Complications of measles may be serious and include pneumonia and encephalitis. 25% of measles cases require hospitalization, and 1 or 2 cases out of every 1,000 will die. Measles is spread via airborne and respiratory droplet routes of transmission. It is a highly contagious illness, and 9 out of 10 people exposed will become infected if they are not immune. Infected individuals can spread measles before they know that they are sick, since they are infectious from 4 days before until 4 days after their rash appears. People who become ill will typically develop symptoms 14 days after exposure, with a range of 7 to 21 days. 2019 has seen the most cases of measles in the United States since the disease was eradicated. As of April 26, 2019, there have been 704 cases of measles in the United States. CDC updates national case count data every Monday, and the latest case count data are available on their website. An outbreak of measles is defined as 3 or more cases linked in time and space. As of April 26th, there have also been 12 outbreaks in the United States since the start of 2019. Currently, there are 9 active outbreaks, including a large outbreak in Rockland County, New York, and New York City that began during 2018. These outbreaks are related to international travel in countries with large measles outbreaks, including Israel, Ukraine, and the Philippines. A list of current active measles outbreaks is available on the CDC website. During 2019 in Connecticut, we have seen 3 cases of measles. There has not been a measles outbreak in Connecticut. Sporadic cases in Connecticut are not unexpected due to the large outbreaks of measles occurring in other states and internationally. Connecticut Department of Public Health routinely communicates with public health partners and the general public regarding measles activity in the state. Health advisories are used to share information with health providers and local health departments. Press releases are used to share information with the general public via the media.
The best way to protect against measles is with the measles, mumps, and rubella vaccine, or MMR vaccine. MMR vaccine is recommended as part of the current pediatric vaccine schedule. Children usually receive their first dose of MMR vaccine between 12 and 15 months of age. Children typically receive their second dose of MMR vaccine between 4 and 6 years. However, this vaccine may be given earlier as long as the minimum interval and age are valid. MMR vaccination is highly effective. A single dose of MMR is 93% effective and 2 doses are 97% effective. Individuals who receive MMR vaccine as part of the routine pediatric series or later in life are considered to have lifelong immunity. MMR vaccine may be given as young as 6 months of age for individuals with international travel or during outbreaks of measles. While this will offer protection, it is not considered to be a valid dose as part of routine childhood vaccines and should be repeated at 12 to 15 months and 4 to 6 years. In Connecticut, measles vaccine is required for school attendance. 1 dose of MMR vaccine is required for students in preschool, and 2 doses are required for students in kindergarten through 12th grade. Alternate evidence of immunity, such as a titer, may also be submitted in place of vaccination. In Connecticut, students without vaccine can comply with school entry requirements by submitting a medical or religious exemption. Medical exemptions are rare and may only be submitted by a physician if a child has a valid contraindication to MMR vaccine. Religious exemptions require an acknowledged written statement from a parent that receiving the vaccine is contrary to the religious beliefs of their child. In Connecticut, we have a highly vaccinated population with 96.5% of students receiving MMR prior to kindergarten entry, according to the 2017 to 2018 School Immunization Survey. Despite this success, we do know that there are some pockets with under-immunized students that may be at greater risk if a measles exposure were to occur. During a measles investigation, there are several steps that are taken to identify cases, implement control measures, and communicate with public health partners. Measles investigations are a collaborative effort between DPH and local health departments. DPH is responsible for investigating reported cases, confirming the diagnosis, and coordinating the investigation. The local health department is responsible for implementing local control measures. Measles is a Category 1 condition. This means physicians and laboratories must immediately report suspected cases of measles to DPH and the local health department where the case resides. DPH has 24/7 coverage for measles calls. DPH works with a medical provider to describe clinical signs and symptoms, assess epidemiological risk factors, and coordinate clinical testing. It is important to point out that not everyone with red spots has measles. Many febrile rash illnesses get reported to DPH for investigation. However, very few of these reports turn out to actually be measles. The first step in any measles investigation is to confirm a diagnosis. This will determine what control measures are appropriate. We do not recommend taking any action, including sending letters home to parents, until a diagnosis has been confirmed. Once a diagnosis of measles is confirmed, we will work with the case to determine their movements in the 4 days before and 4 days after their rash onset. Measles virus is transmitted by direct contact with droplets or by airborne spread. Measles may remain in the air for up to 2 hours after an infected person leaves the area. Therefore, for each exposure, we will try to identify individuals that were in the same area as a case from the time they arrive until 2 hours after they leave. In ideal circumstances, we will develop a line list with contacts. This line list can be used to assess the immune status of each exposed individual, document if post-exposure prophylaxis was given, and determine if they spend time in a high-risk setting such as a school. Examples of these settings include healthcare facilities, schools, social gatherings, and household contacts. In some settings, exposed individuals cannot be identified. In these circumstances, a letter is sent out to notify individuals of their exposure. Examples of these settings include religious settings, fitness centers, and other public places. DPH and the local health department will contact each exposed individual when possible to assess their immune status. A person is considered immune to measles following an exposure if they have written documentation of one of the following. They received 2 doses of measles-containing vaccine and are a school-age child, grades K through 12, or an adult in a setting that poses a high risk for measles transmission, such as college, healthcare personnel, or international travelers. Or they received 1 dose of measles-containing vaccine and they are a preschool-age child or an adult who will not be in a high-risk setting for measles transmission. They can also submit laboratory confirmation of measles infection, laboratory confirmation or titers of immunity to measles, or if they were born before 1957. Post-exposure prophylaxis may be given to individuals without documented evidence of immunity. MMR vaccine is protective if given within 72 hours of a person's first known exposure. It may be given to anyone 6 months or older without a contraindication to MMR vaccine. MMR vaccine is typically readily available, and individuals that receive MMR vaccine are able to return to normal activities. Unfortunately, since individuals with measles are infectious before symptoms develop, it is not always feasible to administer MMR vaccine within 72 hours of an exposure. Immune globulin is only given to individuals with high risk of complications, including infants, pregnant women, and immunocompromised individuals. Immune globulin must be given within 6 days of the first known exposure and is typically administered in an emergency department. Individuals who receive immune globulin may still develop a milder measles infection and must remain at home for 28 days after their last known exposure. If a school-age child or staff is identified through contact tracing, for example, the child attended the same social gathering as the case, DPH or the local health department will assess the immune status of the exposed individual. It is important to note you will not be asked to make judgments about school restriction based on a measles exposure. The health department will give you clear guidance regarding what control measures are needed. They may return to school if they are immune. If they are not immune, they may not return to school until 21 days after their last exposure. If they are not immune and received immune globulin, they may not return to school until 28 days after the last exposure. There are no special recommendations for siblings or other household contacts, and there are no recommendations to send a letter home to parents in this situation.
The second possible scenario that you may encounter would be if a measles exposure occurs in your school. If an exposure occurs in a school setting, you will need to work with the health department to assess students, staff, visitors, extracurricular activities, and other entities or organizations that use your school facility. The simplest group to assess following a school exposure is students. You should have vaccine records for all students in your school. Based on these records, you can identify any students who are not appropriately vaccinated for their age. These are students that are either non-compliant or have a religious or medical exemption on file. These students will need to be excluded from school unless they are able to provide evidence of immunity, such as titer results. Students may return to school if they are able to receive MMR vaccine within 72 hours of their first known exposure. A list of exposed non-immune students must be shared with DPH and the local health department for active monitoring. The second group to assess are staff. Staff are typically challenging as most schools do not routinely collect documentation of measles immunity. All staff must present written evidence of immunity to return to work, which may include documentation that they had received 2 doses of measles-containing vaccine, laboratory confirmation of previous measles infection, laboratory confirmation or titers showing immunity to measles, or if they are born before 1957. For staff without documented evidence of immunity, if staff only have 1 dose of MMR, they can receive a second dose and return to school immediately. Staff with no documented doses of MMR vaccine should receive titers. Staff without evidence of immunity must be excluded from school for 21 days after their last known exposure. A list of non-immune staff must be shared with DPH and the local health department for active monitoring. The third group that a school will need to assess are visitors. Schools can often identify visitors based on school visitor logs. Depending on the information captured on your visitor log, there may or may not be contact information such as phone number and email addresses. The Department of Public Health and the local health department will work with the school to determine the best way to notify visitors on a case-by-case basis. The fourth group to assess are individuals participating in extracurricular activities that occurred both on and off the school campus, such as field trips, sporting events, and other gatherings. A list of extracurricular activities must be shared with DPH and the local health department, and we will work with you to determine the best way to manage exposures at these events on a case-by-case basis. The last group to consider are outside entities that may use your school facilities. These could include on-site preschool programs, before and after care programs, and other groups that use your school facilities. For example, in my town, the swimming pool at our high school is open for residents to use during scheduled hours. A list of these organizations and entities must be shared with DPH and the local health department, and we will work with you to determine the best way to manage exposures related to these other groups using school facilities on a case-by-case basis. Exposed individuals should receive written guidance, so schools will often send home a letter if an exposure occurs in a school setting. These letters should include information on the date the exposures occurred, signs and symptoms of measles, and how to safely seek care if someone suspects that they have measles. Individuals with a known measles exposures should call their medical provider before seeking care. A template letter is available, and DPH is happy to review any written materials prior to distribution.
We know that a call about measles can instill panic in even the most experienced school nurse. Before doing anything, reach out to DPH in your local health department for guidance. We are available to help you with anything from investigating rumors about the mom who called you to say their child was just diagnosed with measles, even though they really weren't, to managing a full investigation related to an exposure in your school.
Thank you for taking the time to listen to this presentation. If you have any questions, we encourage you to reach out to us by email. An epidemiologist may also be reached Monday through Friday from 8:30 to 4:30 for routine inquiries using our immunization program number. An epidemiologist is also on call 24 hours a day, 7 days a week for urgent matters and may be reached via the after hours number.